Namaste Bitiya, Hamisha Khush Raho Bitiya. A very good morning to you all. Myself, JB and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University Chapter. In this series of lectures, we are discussing about the different type of hematological diseases. In the last lecture, we were discussing about hemolytic anemia. And today we are going to continue with that hemolytic anemia. So in the last lecture, we have discussed about the different causes, the classification of the hemolytic anemia, the different causes for development of hemolytic anemias. And also we have discussed a little bit about hemoglobinopathies. So in today's lecture, we are going to continue with the previous lecture of hemoglobinopathies. What is hemoglobinopathy? Hemoglobinopathies are the disorders that are affecting the structure, function, and production of hemoglobin. This we have discussed in the last class, but this we have to keep into our mind that what is hemoglobinopathies? As the name suggests, hemoglobin and pathy means disease related to the hemoglobin. So these are the disorders. Hemoglobinopathies are the disorders that are responsible or that are affecting the structure, function, and production of the hemoglobin. So these are affecting the structure, these are affecting the function and the production of the hemoglobin. The diseases are caused, the hemoglobinopathy diseases are caused by the dysfunction of the gene that are encoding the globin chain of the hemoglobin molecule. So hemoglobinopathies are basically the disorders that are affecting the structure, the function, and the production of hemoglobin. So these are affecting the structure, the function, and the production of hemoglobin, and the diseases are caused by the dysfunction. So any of the hemoglobinopathy that it is caused due to the dysfunction of the gene encoding the globin chain of the hemoglobin molecule. So hemoglobinopathies, these are the disorders that are affecting the structure, function, and production of hemoglobin. The diseases are caused by the dysfunction of the genes. So the dysfunction of the genes that are encoding the globin chain of the hemoglobin molecule. There are different types of hemoglobin that are produced during the embryonic phase, fetal phase, and the adult life. So we are talking in this lecture, we will be talking about the different types of hemoglobin that is produced at different times, the disorders that are related to the structure of that hemoglobin, the functioning of that hemoglobin, and its production. So there are different types of hemoglobin that are produced during the embryonic phase, the fetal phase, and the adult life. Normal hemoglobin, it is comprising of 2 alpha genes and 2 non-alpha genes, globin genes. So in hemoglobinopathies, there is, or whenever we are talking about the normal hemoglobin, a normal hemoglobin consists of 2 alpha genes and 2 non-alpha genes. This you must have studied in the physiology. So this is just a revision of that particular thing. Now, classification of hemoglobinopathies. How can we classify hemoglobinopathy? There are 5 major classes of hemoglobinopathies. So, in hemoglobinopathy, we are going to discuss about the 5 different types of hemoglobinopathies. That includes number 1, structural hemoglobinopathies. Number 2, we will have thalassemia. So, structural hemoglobinopathies, thalassemias. So we have 5 major classes of hemoglobinopathies, which includes number 1, structural hemoglobinopathy. Number 2, we will have thalassemia. Number 3, thalassemic hemoglobin variants. Next, we will have hereditary persistent fetal hemoglobin, and the 5th variety is acquired hemoglobinopathies. So what are the 5 varieties? We will be having structural hemoglobinopathy, thalassemia, thalassemic hemoglobin variations, hereditary persistent of fetal hemoglobin, and acquired hemoglobinopathies. So structural hemoglobinopathy, thalassemia, thalassemic hemoglobin variants, hereditary persistence of fetal hemoglobin, and acquired hemoglobinopathies. Now let's start with the diseases one by one. So the most important disease that we are going to see in case of hemolytic anemia or hemoglobinopathies is the sickle cell anemia. This is the most common disease that we encounter in this particular disease condition. So what is sickle cell anemia? Sickle cell anemia is basically an inherited disorder, and it is inherited as an autosomal recessive trait. So we have inherited recessive autosomal recessive trait, and there are homozygotes only produce normal beta chain that make hemoglobin S chain, HbS, that is termed as SS, and this results in the clinical syndrome of the sickle cell syndrome. So sickle cell anemia is inherited as an autosomal recessive trait. It is homozygous, only produces abnormal beta chain that makes the hemoglobin S chain, that is termed as SS, and this results in the clinical syndrome of sickle cell disease. Now, what is the pathogenesis? In the pathogenesis, when hemoglobin S is deoxygenated, so when the hemoglobin S is deoxygenated, the molecules of hemoglobin polymerize to form pseudocrystalline structures known as tectoids. So this tectoid formation, I believe you must all have studied in the physiology first year. So if you have forgotten about it, then just go to the physiology and just have a quick review of this tectoid formation. So what happens in sickle cell anemia is, in the sickle cell anemia, it is basically a autosomal recessive trait, and the homozygotes only produces abnormal beta chains. So there is abnormal production of the beta chains that makes the hemoglobin S. So HbS termed as the SS, and this results in the clinical syndrome of sickle cell anemia. Now, what is the pathogenesis? In the pathogenesis, the hemoglobin S is deoxygenated. When the hemoglobin S is deoxygenated, then the molecule of hemoglobin polymerize. So the molecules of hemoglobin, they polymerize in the deoxygenated phase one over the other to form a pseudocrystalline structure that are known as tectoids. And these distorts the red cell membrane and produces characteristic sickle-shaped cells. So when the hemoglobin S is deoxygenated, the molecules of the hemoglobin polymerize to form pseudocrystalline structures that are known as tectoids. And these distort the red cell membrane and produces characteristic sickle-shaped cells. So the tectoids, this distort the red cell membrane and they produce the characteristic sickle-shaped cells. Now, what are the clinical features of a sickle cell anemia? When the patient is coming to us for the sickle cell anemia, what are the various clinical features? So the clinical features will include hypoxia because of the decreased oxygen capacity of these hemoglobin molecules or the red cells. There will be hypoxia. There will also be acidosis, dehydration, and infection. So we will observe hypoxia, we will observe dehydration, we will observe acidosis and infection. There are irreversibly sickled cells that have shortened survival and plug vessels in the microcirculation. So the clinical features that you are going to see in case of sickle cell anemia is the hypoxia, acidosis, dehydration, and infections. Now, what does these type of cell produce? They produce irreversible sickled. If they become irreversible, normally this is a reversible process, but if they become irreversibly sickled, and they have a shortened survival and they plug into the vessels of the microcirculation. So because of this, these permanent sickle cell formation, they get destroyed and get plugged in the microvasculature. This results in a number of the acute syndrome that is known as the crisis and the chronic organ damage. So this results in the crisis and chronic organ damage. So there are different types of crisis that we are going to see. This includes vaso-occlusive crisis. We have vaso-occlusive crisis. Then we have the sickle chest syndrome. Next, we have sequestration crisis and aplastic crisis. So there are different types of crises that we are going to see. First is vaso-occlusive crisis. Then next is sickle chest crisis, sequestration crisis, and aplastic crisis. I have also uploaded the e-notes on the portal. So if you feel any kind of problem in understanding these things, then you can refer to the e-notes that I have uploaded on the portal. So let's discuss about number one, vaso-occlusive crisis. So vaso-occlusive crisis is the most common type of crisis. This is the most common crisis that we are going to observe. And plugging of the small blood vessels in the bone produces acute and severe bone pain. So if these sickle-shaped cells gets plugged in the small vessels and in the bone, they produce severe acute bone pains. And this affects the active marrow, the hands and feet of the children. So leading to the dactylitis, that is inflammation of the finger formation. and systemic response to tachycardia, sweating, and fever is observed. So what happens in vaso-occlusive crisis? That it is the most common type of crisis, and we have plugging of the small blood vessels in the bone that produces acute severe bone pain, and this affects the areas of the active bone marrow and leads to the feet in the children. That is called as dactylitis. So there is inflammation of the fingers and systemic response to tachycardia, sweating, and fever takes place. The second variety is the sickle chest syndrome. Now, what happens in the sickle chest syndrome? It is follow on from the vaso-occlusive crisis. So after the vaso-occlusive crisis, we have sickle chest syndrome, and it is the most common cause of death in adult sickle disease. So in the adult with sickle cell disease, vaso-occlusive crisis is responsible for the major deaths. There is bone marrow infarction that results in the fat emboli. So there is bone marrow infarction that results in the fat emboli in the lungs, and it causes further sickling and infarction, leading to the ventilatory failure if it is not treated. The next variety is the sequestration crisis. What happens in sequestration crisis is there is thrombosis of the venous outflow. So there is thrombus formation of the clot formation of the venous outflow from the organs, causing the loss of function and acute painful enlargement. So what happens in the sequestration crisis? We have thrombosis of the venous outflow from the organ that causes loss of function and acute painful enlargement. The spleen is the most common site of sequestration crisis. There is massive splenic enlargement. This may result in severe anemia and circulatory collapse and death. So sequestration crisis, this result in the thrombosis of the venous outflow from the organ that causes loss of functions and acute painful enlargement. The spleen, it is the most common site. The massive splenic enlargement may result into severe anemia, circulatory collapse, and death. Next, we come to the aplastic crisis. What happens in aplastic crisis is there is infection of the acute adult sicklers with human erythrovirus 19 that results in severe but self-limiting red cell aplasia. And this produces a very low hemoglobin that may cause heart failure. So in aplastic crisis, there is infection of the adult sicklers with human erythrovirus 19, and it results in severe but self-limiting red cell aplasia. This produces a very low hemoglobin and it may cause heart failure. Now, what are the various investigations that can be done in hemoglobinopathies or hemolytic anemias? So different investigations include the patient of the sickle cell disease have a compensated anemia. So in such patient, in the patient with sickle cell disease, you are going to observe compensated anemia. So there is some sort of changes that are occurring in response to anemia. The blood film shows sickle-shaped cell, target cell, and these are features of hyposplenism. If the reticulocytes are present, the hemoglobin electrophoresis to demonstrate the absence of HbA and the predominance of HbS. So in the investigation, we have to check for sickle cell disease. They have compensated anemia. The blood film shows sickle cells, target cells, and the features of hyposplenism. A reticulocytosis is present and hemoglobin erythropoiesis to determine the absence of HbA and the predominance of HbS. Now, how to manage such case? Whenever a case of sickle cell anemia or hemoglobinopathy is coming to us, how can we manage such case? All the patients with the sickle cell disease have to receive prophylaxis with daily folic acid. So we have to supplement daily folic acid to such patients and penicillin V to protect against pneumococcal infection. In case of vaso-occlusive crisis, it is managed by aggressive rehydration. So we are giving IV fluid, oxygen therapy, and adequate analgesics and antibiotics. So in case of vaso-occlusive crisis, these are managed by rehydration, aggressive rehydration, oxygen therapy, adequate analgesia, and the antibiotics. The transfusion with fully genotyped blood wherever it is possible is done. So blood transfusion is there. And oral cytotoxic agents like carboxylamide has been shown to have clinical benefit in children and adults who have recurrent severe crisis. Next, we have allogenic stem cell transplant from the HLA matched sibling. So in case of advanced cases, we can go for allogenic stem cell transplant from the HLA matching siblings. So in the management, we have to give daily folic acid, penicillin V. In the vaso-occlusive crisis, it is managed by aggressive rehydration, oxygen therapy and adequate analgesia and antibiotics, transfusion of the fully genotyped blood, oral cytotoxic agents, hydroxycarbamide, and allogeneic stem cell transplantation. So this is all about hemoglobinopathies and hemolytic anemia. In the next lecture, we are going to start with a new topic. So this topic is over. I hope you have understood this session. This session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope the session is clear to you. If you have any query, you are free to write in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.